Thanks everyone for joining in time. Welcome back to the second part of this session that we started yesterday. Um, for those who couldn't join yesterday and only joined today, this is a workshop that we're looking at HIV prevention needs estimates for generalized epidemics, focusing on ESA and WCA. As you can see on the dates on the lower left panel there, we started yesterday, and today we are continuing with the same agenda. We have French and Portuguese interpretations available. And as we highlighted yesterday, we'll make sure that the slides shared during these workshops will be made available to you together with the accompanying recording. Just like yesterday, which was very engaging, people asking questions, people posting things in the chat. We want to make this a very engaging session. So feel free to make comments, ask questions. To be able to follow through on the different questions, I'd like to ask that we separate the questions and general comments or feedback or reflections. We put questions in the Q&A function, and then we can put general comments and other reflections in the chat general function. My name is Lisa Zembe. I'm with the Global HIV Prevention Coalition Secretariat at UNAIDS, and I'll be chairing this workshop together with my colleagues. We highlighted the objectives of these sessions yesterday, and we also share these slides for those who missed the yesterday session. And also, as we highlighted yesterday again, there are a series of these workshops for the different regions and different epidemics is highlighted in the top right panel for the different dates. For generalized epidemics, it was yesterday and continuing today, and then for the other epidemics and regions, as indicated on the dates there. The agenda, is as you can see from this slide, we started the top panel that is highlighted in a red rectangle. That's what we covered yesterday. Overall introductions, we covered two of the tools, the SHIP 2 and the PREP 2. And then today, we are going to continue covering other tools relevant for these regions. So we're going to be looking at the CNET 2, looking at estimating condom need and how that is done in Spectrum. We'll also look for those relevant countries where this is applicable, VMMC needs estimate as it is done in Spectrum as well. Today, we'll also cover cost effectiveness modeling using the GOES model. And my colleague will provide some kind of an overview of how these different tools fit together so that we have a better understanding of how the different tools are used. And then we have an exercise today that would like to be more engaging and feedback and reflect on how we can apply this to the Global Fund GC8 applications. That's all from me. So I would like to hand over to my colleague Heather Marie so that we can just reflect in few minutes about yesterday's session. And then after Heather Marie, my colleague Clemens will just provide a quick overview of how these different tools fit together so that we've got that understanding before we can start the presentations for today, starting with condoms. So over to you, Heather Marie, and after you can hand to Clemens. Thank you.
Thank you, Lisa. And so we have a few questions for everybody here just to get the ball rolling, find out how you felt about yesterday. So if you have a phone, please scan the QR code. And if you do not have a phone, you can go to www.menti.com and enter the code 5370915. And this will continue to appear as I'm going through the slides. So the first question, and hopefully a very easy one for everybody who is on today's call, how are you feeling today? How are you feeling at the start of this workshop? We have one great, a frustrated, sleepy, anxious, overwhelmed but optimistic. I feel like that's how I live my life. Excited, Un peu fatigué? Oui. And please remember, you can answer in any language you would like. Motivated. Okay. I'll just give, about 30 seconds more. I like the use of emojis for those of you who are using your phone. Feliz. Okay. That's wonderful. And you can continue to click the thumbs up if you like. All right. So how confident, after yesterday's workshop, how confident are you feeling in using the spectrum prevention needs estimates for national planning? And so just strongly disagree that you're confident, so very unconfident, 0, very confident, a 5. It was a very quick whistle-stop tour. And just wait another few seconds for people to, for you all to have an opportunity to answer. And great to see more people joining the Mentimeter. We will come back to the Mentimeter at various times later during this session. Okay, so people are kind of in the middle, like you're feeling okay. Not necessarily very confident, but most people are not feeling completely at a loss with this yet. And then the final question for this session, or this part of the session, is, did you have one thing, just one thing, that you took home from yesterday's workshop? Whether it was about SHIP, whether it was about PrEP, whether it was about the just spectrum and using it for prevention more broadly. PrEP person use. Be careful on Zoom. Yes, we hopefully have learned that lesson. See, a couple of people liked PrEP person use. Too many tools. And a few people hadn't missed it. Okay, so maybe 10, 15 more seconds, and then I will hand it back to Lysias.
Thank you so much, Heather Marie. Very interesting reflections from colleagues, and thanks for responding. It also helps us to shape how we can have the discussions today. Looking forward to a very engaging session today. I want to hand over to my colleague Clemens to just share a slide that will put together these different tools and maybe make some clarification that makes it very easy for us to then understand the rest of this session today. So over to you, Clemens.
Thank you so much, Lysias. And I will take over the screen now as well. And as you already mentioned, I think one question we got yesterday and also today, it came out in the survey just now, is many tools. How do the different tools fit together? And we have prepared one slide for that, just to answer this. And I hope you can see my see the presentation now, the slide. And As mentioned yesterday in the introduction, the purpose of these prevention needs estimates in Spectrum is really to routinize HIV prevention needs estimation. There are many other very specific tools, but what we do not have is a place where all countries, just like we do for HIV treatment, where we estimate our annual number of people living with HIV, and then we can actually work towards the 95, 95, 95 targets. We wanted something that is as routine for HIV prevention, where we have an exercise to quantify the need on an annual basis, and do it and actually not separately through different tools, which will require a lot of effort, but routinized as part of an exercise that countries already engaged in, that are country-led and have a strong, solid basis in the Spectrum process. So that was really the idea. Now, in an ideal world, maybe one day one could have a supermodel that can do everything. But one could argue that we often have specific purposes that should not necessarily require actually us to, use a full model with all the different capabilities, but do more specific things. And this is why we have actually, sorry, did we lose the sharing? I was kicked out for a moment. So that's why we actually also still have the specific tools. So prevention needs estimation, overall synthesis for all populations, people, and products is what Spectrum is proposing. However, if you want to dig very deep,
Clemens, sorry to interrupt. Would you put in a presentation mode?
okay, let me reshare. I had it in presentation mode at the beginning, right? And then I was is it back in presentation mode? I hope it is.
Yes, perfect. Thank you.
Okay. So yes, so we have very specific tools then, for subnational epidemic in Africa and understanding pop sizes by behavior and incidence, the NAOMI and SHIP tools, with the SHIP tools actually going more detail in terms of behavioral disaggregations. We have, and we've seen it yesterday, we have allocative efficiency and cost effectiveness models that really have that program and costing component in there to compare, cost per infection averted, for example. And then we have, for the two main interventions that cut across different populations, which is PrEP and condoms, we still have the detailed tools, which have some additional planning capabilities, which, to keep it simple, are not yet part of the Spectrum tool. So for detailed PrEP needs planning, which you might not do every year, but might do at very specific moments, you could do a PrEP application, or for very detailed condom needs planning, that also goes then into sort of that market shaping, different program shaping with different roles for public, social marketing, and private sector. The condom needs estimation tool goes further into that, as we will see today. So that's maybe just in terms of the big picture. The idea is really to reduce the number of tools to have one integrated platform where we even include, prevention and treatment in the same, Spectrum overall platform, and then we have those specific tools. And since the question came up on the Global Fund LEN quantification, well, that's a very specific purpose that would come here sort of under the PrEP implementation tool. And it should, of course, not be a national target setting tool. Target setting should be based on these overarching tool, and then specific funders might still need to, for their own quantification and supply chain, estimate specific needs using a more specialized tool for a product. But what should guide national responses overall is this set ideally, or of course any country-specific tools like TIMBISA and so on. So I'll end here. Maybe I hope this helped clarify a bit how the different tools fit together and what is really new in sort of routinizing this in Spectrum? Thanks.
Thank you. Thank you so much, Clemens. So we're going to start now with today's presentations, continuing with these different tools. Linking to yesterday, highlighted earlier on, we had an overall introduction of the estimates processes and how the prevention needs estimates links to that process. Also, how this is related to the HIV prevention access framework that Clemens highlighted yesterday, and also an overall introduction to the Spectrum suite of tools on prevention needs estimates. Then we cover those tools, the SHIP tool for estimating sub-national population sizes that are at high risk, then how to estimate PrEP need. Then now we're starting on how to estimate the need for condoms. And for this presentation, I'm going to ask John Stover, who's going to provide a presentation on the assumption in Spectrum. And then we'll ask our colleague Henk from UNAIDS, who's going to present on CNET. Then we'll hear from Uganda, a country example of using that tool. And then we'll get into a Q&A session. So over to you, John, on the condom part of the Spectrum suite of tools on prevention needs estimates. Thank you.
Thanks. Can you see my slides all right?
Yes, they are looking good. Thank you.
Okay. So this will talk about a few slides of introduction for the condom needs tool. First of all, just to remind you of the purpose here, this tool is designed to assist you to estimate the condom needs for achieving whatever national targets you set for yourself. And the approach we take here is to set the target in 2030 and then have a linear scale up from wherever we are today to 2030. Well, first, why is this important? So according to your reports to GAM, in the countries represented in this workshop, Sub-Saharan Africa, almost 2 billion condoms were distributed in 2024. It'll be interesting to see what that total looks like when the 2025 numbers are in. And this is what's reported by country, so there may be some additional, private sector that don't get reported. But in any case, 2 billion condoms, so it's a big number. I think it's also important to think about what have been the trends in condom use in your country over time. So this chart is showing you for a few countries that have had DHS and FIA and AIS surveys, the self-reports by men of condom use at last higher risk sex over time. You can see for most countries, the trend is flat. Some have a few slightly declining trend, a few have slightly increasing trend. I think it's important to keep these in mind because when you're looking at targets, we want to compare the 2030 target with where we are today. If there's a big gap, you have to ask yourself, are we going to get there naturally through what we're doing now, or do we have to do something different to reach that target? So I think that's going to be an important part of the target setting, is to make sure that the targets are feasible and that you have some plan for how you're going to achieve that target. So in the global strategy, there are a few of these targets that mention condoms. First is that 90% of all people in need of prevention services should be using one or more prevention options, one of which, of course, is condoms. There's also a target that at least 95% of the estimated need is available and distributed. And then finally, a specific target for people who have non-regular partners of 80% condom use at last sex. So those are the targets that are set in the global strategy. You'll have a chance to review those and set others when you look at the tool. Just as note that if we talked about 2 billion condoms distributed in 2024 in this region, if all the targets in the global strategy were met, that would imply a total need of a little bit over 6 billion. So there's a big difference between where we are today and where we might be if we achieved all of those aggressive targets. All right, so here's what the tool, sort of overview what the tool looks like, and we'll go into looking at the actual tool in a minute. But what you have on the left is the different population groups. that we're considering setting targets for. So you can review that list of population groups. And then in the next two columns, we have the population size, so the number of people in those each group. And this is drawn from the demographic estimates and projections, mostly from the World Population Prospects 2024. And for those people who have multiple partners or non-regular partners, we also use the results from your latest survey that indicate the proportion of people that engage in non-regular partner sex. And then the third column there under baseline coverage, this also comes from your national surveys. So that's all in red. That will be filled in automatically from a database when you open up the tool for yourself, but you should review them because perhaps you have more updated data or you see something that doesn't look right to you. So you can change any of these numbers, but it will be pre-populated in order to get you off to a quick start. Then the blue column in the middle is the target coverage. And as I mentioned, we have targets for non-regular partners, but the others, it's up to you. We've given you some illustrative targets here, but it's up to you to review those and set those. The next box on wastage and sex acts, we don't have really good data on this. So these are sort of the standard figures that we use, but something that you can change, and I'll explain a little bit later on why you might want to do that. And then on the right, we have the total requirements by year and by population group. So here, one thing that you want to do is, see if I can get a pointer here. All right, can't see my pointer options. Oh, it's not coming up. Anyways, if you look at the bottom of the column that says 2025, that's giving you a total. So in this particular example, it's showing 83 million condoms. You'd want to compare that with whatever data you have from your program on number of condoms distributed and make sure that they're fairly similar, because if they're not, then you're starting off from the wrong place and we want to make some adjustments. But assuming that that's correct, then the other columns are going to show you the annual requirements as you approach the 2030 targets. And the bottom line there shows you the annual increase in condom availability required to achieve those targets. So this gives you a chance to look at what these targets imply and what the annual growth rates would be, and consider whether these are reasonable or not. You can change any of the inputs in the red and blue boxes. And as soon as you make a change, the green box with the results will automatically update. So you'll be able to see right away what the effect of your change is. Okay, so when you're using this, we'll have an exercise in a few minutes, but when you're using this, a couple things that you should consider. First is, are the estimates of the number of female sex workers and MSM accurate? Elena's going to talk about later on where those come from, but particularly for FSW, that's an important component usually of condom needs. So you'll want to make sure that you have your most updated estimate of population size there. The second one, as I already mentioned, about is it feasible to reach these global targets, considering where you are today and past trend. The tool will show you how many condoms would be required to achieve the target, but if you're going to accept that, you're going to have to think about what do we need to do differently over the next few years in order to do that. The third one is that, all the analysis that we talk about, and I think Rob will show this later today, is that condom programs are highly cost effective and are actually cost savings in most situations. So these are really critical to a cost-effective prevention program. Any deterioration in condom availability that could come about because of the recent funding cuts could have serious consequences. So we need to consider that. Condom programs are not expensive in the overall scheme of things. We need to make sure we protect condom supply. Thank you. So I'm going to stop there, turn it over to Hank to talk about the condom needs estimation tool, and then we'll come back to the hands-on session. Thank you.
Thank you so much, John, for that overview. Now we can go to the next presentation, after which we'll do a country example in the Q&A session. So I'll hand over to Hank, who will present on the CNET too. Over to you, Hank.
Thanks, Lysias, and thank John for that introduction. Oh, I see I'm not on my first slide. So basically, I will present on the condom needs estimates tool, CNET, which now is in its 6.1 version, which many of you might have used in the past. And that basically was developed to starting in 2015 to support a shift in condom programming away from what was very much a condom-driven condom programming towards what we call the differentiated and people-centered condom programming approach that focuses on outcomes and impacts for people, basically, and levels of condom use and reduction of new HIV infections, STIs, and unwanted pregnancies. And that was in line with the targets that were being set for prevention back then and in 2020. Also important in the design of the tool was really to make sure that we adequately identify the needs of priority and higher risk populations, which are often vulnerable, hard to reach and face access barriers. And finally, really also, and that's the country programming experience that speaks, is to bridge the gap between quantification and program design and service delivery. As you all know, there is often a gap of dialogue and understanding between what you, to simplify it, would call the data people, the programming people, and then the community people and the beneficiaries, where that articulation of the data into effective program design and implementation poses many problems. Since then, CNET has been used in mostly in sub-Saharan Africa, in 35 plus countries. A bit a similar message as John, perhaps put a bit more explicitly. This is from today's DHS stat compiler, trends in condom use by men with a non-regular partner. And overall, you see that stagnating or decreasing or low. And just as a rule of thumb, any country where you basically have condom use in sex with non-regular partners below 60%, or where condom use is decreasing, is a missed opportunity to strengthen HIV prevention and to strengthen the impact of HIV prevention and sexual reproductive health. And it's not only the issue of levels of condom use, it's also that and this is an example I'm using from Côte d'Ivoire, it's also that condom programs really are riddled by inequality and inequities. This is a slide showing the trend in condom use in Côte d'Ivoire by wealth quintile for men and women. And you see 3 or 4 things: the difference between men and women, you see the systematic difference by wealth quintile in levels of condom use and decrease, you see the difference over time, and the overall very low condom use where we end up. And this has a lot to do with how condom programs are designed and that do not adequately address the observed inequalities and the underlying inequities. And that's why this focus of this overall, these 2 days workshop on people-centered prevention needs estimates are so important as a first step, because that's the basis that's going to inform subsequently your program design and delivery. And that's where CNET came in and to help bridge that gap. As you have seen, this is exactly the same methodology. The Spectrum methodology has taken over the CNET module of estimating the condom needs with the same key population or priority populations, starting from population size for each of these populations, starting year, and then the issues, the methodology John already explained, which then provides you a baseline for 2025 that's then used to do this linear projection towards 2030. Many of you will be familiar with that. It's exactly the same methodology. Now, where is the alignment and the complementarity now that we have, at the one hand, the condom needs estimates within Spectrum and still having also CNET? I've tried in this slide, and this is all relatively recent, to compare the features in Spectrum and the Spectrum needs estimates and the features from CNET. As John said, and Clemens before that, the big strength of Spectrum is, of course, this systematic global annual process that updates all these estimates, the coherence within the data that is being used, the fact that it covers, if my count is right, 174 countries, and that it will be systematically updated, and that the estimates is user ready and can be also to a certain extent be modified and adapted by the user. And why does Spectrum have so many more countries than CNET? CNET only has 80 countries, is because it has this capacity to use proxy countries to inform countries that do not have DHS or other population-based surveys, whereas that provide the data on sexual activity and condom use that are critical and essential to estimating the condom needs. Where CNET then has always been designed more as both a needs estimates and a quantification and a program design tool, and has a number of additional functions, and on which I will come back. It's really intended, it's not a ready-made estimate, it's really intended to be applied as a multi-stakeholder ownership and partnership building process. There is an elaborate user guide that explains and shares experience on how this process can be implemented at country level. As said, it has been applied for the past nearly 10 years in a number of countries, and capacity has been built. I've already explained why only 80 countries. It uses only the countries with population-based services. It does allow full control over all data and assumptions that are used to conduct the estimates. And it also, and that is an important point, and that's part of that process that's so important, and the stakeholder involvement. There is a lot in the end that when you go into the detailed data, the granularity of data for specific populations, there is quite a bit of gaps and uncertainties on certain data and assumptions. And then it's very important that you have this process, stakeholder involvement, to use the local knowledge and the consensus building so that you have an estimate that is fully owned by the country and by the stakeholders. You can also adapt the tool. It requires quite a bit of effort to include additional populations, define other priorities, but some countries have done it quite successfully. For example, Thailand, to fully adapt it to their context, and it includes a multitude of tables and figures. At this stage, my recommendation is really to, as we haven't done this yet, to use both tools. Spectrum is ready-made. Compare the results, check if there is inconsistencies, let us know. For countries that are not included in CNET, you can just use the Spectrum estimate. And if you want to use CNET, you can transfer the data into CNET and do it and use it for your country. I would also recommend, if you use CNET through a full process with country validation, that you update the Spectrum estimate with these validated estimates. As was explained yesterday, these data then become part and parcel of the Spectrum databases. A few complementarities, I'm mindful of time. In addition to the estimates where we spoke about already, CNET will allow you to define a commodity mix and estimate the needs in this commodity mix for each population. And then we're talking about the mix between male and female condoms, specialty condoms, which are basically condoms with different characteristics, smell, color, size, etc., texture. And also it allows you to estimate extra lubricant need for each population. Finally, it allows you also to directly inform your program design by allowing you to develop or supporting you to develop the total market scenario by defining which TMA pillar would be best suited to provide condoms to each of the population groups. Important in that is that you start from who really needs the free condoms, the public free condoms, basically the people for whom the cost of paying for condoms would be a barrier to accessing and using condoms. And finally, it allows you to do, based on the UNFPA procurement price list, an estimate of your total community procurement cost per population, TMA pillar, and condom product mix. This, for those familiar with CNET, at the bottom you see basically it's an Excel-based sheet tool. These are the different sheets at the bottom of your Excel sheet screen. You go to the dashboards sheet, and there you select your country, and you can also select your language. It's possible CNET will then be used in French, Spanish, or Portuguese. And then it will set up the estimate. And that will then provide you the sheet with the estimates. Now, critical in the use of CNET is what we call the demographic data sheet. And that's where the user can review, update, validate every single data point that is being used in the CNET estimates. It is around 110 data points in 8 sections. And you can see in blue, the cells in blue allow you to change the value that is then being used in the estimate. And it compares it on the left with the data that are the standard data that are being used by CNET. This process of jointly reviewing, validating these data and updating them is critical because it creates a lot of analysis and understanding and ownership on what's happening with condoms, condom use, condom programming in the country. I'm not going to show more of the features of CNET. This is just the sheet where you see the results of the estimation of the commodities need and the cost of the commodities. It's pretty small, but you see expressed in US dollars how much your condom commodities will cost by TMA, by commodity mix, and by population over the projected years. And it gives you a series of graphs you can use. Now, condom in the GC8, Global Fund GC8 condom guidance, will recommend you to use the CNET to quantify and to identify your condom needs and your condom gap. They seem to insist on balancing free and sold condom supply and engage commercial and social marketing. And I think this needs to be revised. Estimate free condom needs based on actual use by low-income population, not total demand. I think this needs to be rephrased. The essential first step, given the difficulties and the challenges condom programs have, the decreased condom use, is to really define what is the need of the most vulnerable, the most at-risk population. And from there, then, design the program that will allow you to increase and deliver your services. Just a reference towards a very elaborate CNET user guide that is available on the HIV Prevention Coalition site. The links are there, and it will in detail explain the process of using CNET and the details of applying CNET. Some recommendations, as said, people-centered condom programming is critical to strengthening differentiated and people-centered combination prevention. CNET and the spectrum condom needs estimates are completely aligned and complementary, with CNET bridging the gap from estimates to program design and service delivery. There is still some fine-tuning and harmonization that needs to be done, but that will be best done based on your feedback. So please give us feedback when you use the tools for GC8. And as mentioned, the process at country level and the multi-stakeholder involvement are critical for the quality and the sustainability of your programs. And that's it. And I'm handing over for the country experience from Uganda. Thank you.
Thank you so much, Henk, for that overview. Yeah, we'll quickly go to the next presentation, which is a very quick country example of using this tool that Henk has provided an overview about. So over to you, Boniface from Uganda. And then after that, we'll do a Q&A session. Feel free to post any questions. If you've got any questions, feel free to post them in the Q&A function. We can be following that function to ensure that the presenters respond to the questions. We can also revisit those questions at the end of the presentations during the Q&A session. Over to you, Boniface from Uganda. Boniface, can you hear us? So I do not see him unless he joined with a different name. I can't identify on the participants list. Maybe you could be having a network challenge here.
Lysias, perhaps we can ask if someone else from Uganda is present and can present.
Okay.
Because I'm
Yes,
surprised Boniface is not there.
Okay. Anyone from the Uganda team who is able to go through this quick presentation example of using CNET from Uganda? Otherwise, we could do the Q&A session while we wait, maybe. Once they are available, we can allow them to give the presentation. And the slides will also be available after the session as well, but we'll be on the lookout on the participants list when they manage to join. So yes, let's open it up for Q&A. We have heard these two presentations from John and from Henk on estimating the condom need, how it's done in Spectrum, and the CNET tool, which is more broader, gives more outputs for other programming purposes. Any questions? I think I see one. I see two questions. If you prefer speaking, raise your hand, please, and then we can unmute you, and then you can ask your questions or you can give your reflection. So I see one question here from Heaven Muchinako, which is saying, is the CNET customized for subnational estimation? And this question, I think it will go to Henk. And then is the tool available for sharing? Which the answer to that second question is yes. We will provide a link in the chat. It's available on the Global HIV Prevention Coalition website, but we'll provide the link in the chat. So over to you, Henk, maybe to respond to that first part of the question, which says, is the CNET customized for subnational estimation?
Thank you for that question. No, it is not. It's something we've been struggling with since the beginning. It is theoretically possible to start using it for if you have good data for a region or etc. to do that. But I think with the new data now available from Naomi, and I forget the name of the tool that was presented yesterday on the behavioral risks yesterday, that provide all this information on subnational population sizes. I think it should be possible now to actually do that. It is a bit of work because all your estimates, the quality depends on how good your data are on population sizes, condom use levels for each of these populations by region. And I think a very important comment yesterday was that the more granular that data becomes, the more modeling and estimates based it towards, the bigger your uncertainties become. So at programming level, you really need to find at country level the right balance between trying to be over granular and having important uncertainties and then using your understanding of the programs and the needs on the ground and informing your program like that. But I think theoretically we're now in a better place than, let's say, 5, 6, 7 years ago to try to do that for certain countries. I remember I once did it for South Africa, and that was possible by province. We did it for KwaZulu-Natal, but not all countries have the same level of data for subnational level.
Thank you so much, Henk, for clarifying that. So, for, John, would you have any, especially this subnational, maybe from a spectrum or estimate angle, whether I know it's a
Sure.
different model in Naomi for the subnational estimates, but in spectrum, is this something that is possible, maybe from your angle for
Yes,
condom?
yes, it is very possible. Since the condom tool and the prevention needs tool is a bit simpler, it would be relatively straightforward to do this. What you would do is replace the population sizes and the current use levels with those appropriate to your subnational region. And that information should be available from the from SHIP and from your national survey. So that should be fairly straightforward, and then you'll have your calculations. The limitation is that you could only do one subnational region at a time. It doesn't allow you to stack up multiple ones and see that they add up to the total. But doing it one at a time should be something to be fairly straightforward within that tool. Thank you.
Thanks. That's very useful. And we covered the SHIP too yesterday. For those who missed that, you received the slides on the SHIP and the recording on the SHIP too that John is just highlighted now, linking to this part of the question. I see one hand up. Bogo, over to you for your question. We will ask you to unmute yourself and then you can speak. Our interpreters hope you are ready to also interpret this question. I understand from yesterday. It's French, yes. Over to you. Yeah.
Oui, merci beaucoup. Ma question, c'est par rapport à CNET. Alors, je voulais un peu savoir, parce que là, j'étais en train de parcourir très rapidement le CNET, j'ai téléchargé, mais je constate que les données de la RDC ne sont pas à jour en ce qui concerne l'enquête des HAS. Donc, les données qui sont là, j'ai vu l'enquête 2013, alors que nous avons l'enquête EDEST 2023-2024. Alors, je ne sais pas avec ça, et je pense qu'on ne pourra pas les utiliser. Alors, je ne sais pas qu'est-ce qu'il faudra faire. Est-ce on peut actualiser ça avec les nouvelles données que nous avons de 2023-2024? Alors, ma deuxième question, c'est de savoir, parce que là, dans la présentation, j'ai vu quelque part où, parmi des recommandations, où on nous recommande d'utiliser les deux. Parce que en regardant, en téléchargeant le Spectrum 643, je suis allé dans les modules prévention hier, j'ai vu effectivement, on avait la possibilité d'avoir les estimations. Mais alors, maintenant, s'il faut utiliser les deux, parce que là, j'ai retenu la grande recommandation, c'est pour le GC8, c'est d'utiliser les CNET. Après, plus loin, j'ai vu dans la présentation, on nous demande d'utiliser le deux. Mais je voulais savoir un peu dans votre expérience, en utilisant les deux modèles, en utilisant CNET, les estimations que cela va donner en ce qui concerne le préservatif et en utilisant l'outil Spectrum. Est-ce qu'il y a une différence ou s'il y a une différence, c'est à peu près, on peut l'estimer à peu près à combien? Parce qu'en fait, c'est aussi une appréciation d'un pays à l'autre pour voir le modèle adapté par rapport au contexte du pays. Voilà les deux préoccupations. Merci. Vous m'avez entendu? J'ai fini. Merci.
Oui, oui, oui. Lysias, should I start?
Merci. Oui.
Yes, over to you, Hank, for the
Yeah,
for the response.
thank you. Just to flag, Lysias, that Boniface has arrived, so he has joined. So, merci pour la question de la RDC sur le CNET. Oui, vous avez bien vu qu'effectivement, pas mal de données, des dernières données en CNET, des bases de données, sont pas mises à jour. Mais c'est justement une des forces de CNET que l'utilisateur a toute la possibilité d'utiliser ce que j'ai montré, cette feuille des données démographiques pour justement revoir et mettre à jour les données. Et donc, par exemple, utiliser les dernières données du DHS. C'est notamment, et je pense que Clemens et John ont bien mis ça en évidence, la grande force de l'intégration de ces estimations de prévention en Spectrum, c'est que les données, les bases de données qui sont derrière sont systématiquement mises à jour annuellement, parce qu'il y a tout un dispositif derrière ça. CNET, c'est un travail un peu de moine pour mettre à jour les bases de données. Mais par contre, chaque pays, chaque utilisateur peut compléter, ajouter les données pour avoir exactement les mêmes données. Parce que vous pouvez aussi avoir des données spécifiques au niveau pays que nous n'avons pas disponibles au niveau mondial. Donc, pourquoi les deux? Je pense que la recommandation sur le GC8 du Fonds mondial a été faite pour spécifiquement utiliser CNET, a été développée. Je pense qu'avant que les modules étaient prêts en Spectrum, je pense que vous pouvez autant utiliser maintenant les données, les estimations Spectrum. Par contre, le point que j'ai fait, le bémol que j'ai fait, c'est que parce qu'on n'a pas encore vraiment complètement utilisé les deux outils au niveau pays, qu'on recommande d'utiliser ou au moins de regarder les deux pour voir si c'est consistant. En principe, ils devraient générer des données très identiques parce qu'ils utilisent exactement la même méthodologie. Mais il peut y avoir des petites différences. Et c'est juste en termes de validation. Mais vous pouvez choisir l'outil que vous voulez. Et comme j'ai mentionné dans ma présentation, la force de CNET est surtout dans le processus et les éléments complémentaires qui sont disponibles dans l'outil, notamment par exemple, quand la recommandation du Fonds mondial de développer ton approche du marketing, comment on appelle ça en français? Total Market Approach. donc de différencier les canaux de distribution entre public gratuit, marketing social et des ventes dans le secteur privé. Et ça, c'est une fonction qui existe seulement dans le CNET. Mais vous pouvez, par exemple, démarrer avec le spectrum, l'estimation est là, copier cette donnée de l'estimation en CNET et puis utiliser les autres modules de CNET qui ne sont pas disponibles en spectrum. J'espère que ça c'est clair comme réponse. Merci.
Thank you so much, Hank. And now we see our colleague from Uganda. Boniface has joined to do the presentation on example use of CNET2 in Uganda. So over to you, Boniface, for a quick overview of your experiences using the CNET2. After that, we'll do an exercise where all of us, we can have some walkthrough of how condom need estimate is done in Spectrum. So over to you.
Thank you very much, and good afternoon, everyone, and glad to be here. So I'm basically going to share Uganda's experience on the use of the CNET. I'm from the AIDS Control Program Ministry of Health in Uganda. Yeah, that's basically just the background. Then I'll also provide why we as a country consider the use of the CNET, and then I'll also give us some highlights on the achievements that Uganda as a country has been able to achieve through the use of the CNET. We shall get some lessons that we have been able to gather over the period of time, and then our next steps. So as a program, Uganda basically insists that condoms should be used correctly and consistently. And over time, they have been proven to provide what we call a triple protection against HIV, STDs, as well as unintended pregnancies. We really encourage that condoms should be used consistently. And we realize the condom need at community level really surpasses accessibility. And we equally noted over time that this inconsistency has mainly been related to partly the quantification challenges. There was inconsistent quantification vis-a-vis the need as a program. So coming to that, the country previously used the global formulary system. We used to have Excel sheets that we used to manually tabulate to be able to come up with the quantification need for the country. But realize this was not really very accurate. In 2022, through the support from Global Fund and the Condom SI, we were able to adopt the CNET. And with the CNET specifically, we realize it's data-driven. So we have different population segments. So within the tool, it requires us to have all this data in one place before we can move on. We have the high-risk populations, we have the sex workers, we have the young people. So all that data needed to be in one place for you to be able to complete the CNET. And then, of course, we also able to link it up with our programming as well, the different program needs, as well as the accessibility at community level, the different distribution points. All this was really geared towards improving our health impact. So within the CNET, why we consider the CNET, we realize it also gives us estimates, not just for 1 year. This time we're able to have a projection of about 5 years. So what have we been able to achieve as a country? Through the use of the CNET, we realized we are able to do more targeted. We call it precision targeting of the most at-risk populations. So we're able to come up with our condoms and lubricant need, which is really near actual. And then we also utilize the CNET for GC7 application, which was really able to give us not just only the cost for commodities, but it was also able to give us the cost for programming as a program in totality. Through the use of the CNET, it also sort of opened our mind. We realized that, yes, previously we used to have quite a lot of stock at our national warehouses. So we would think we're overstocked. But now the Senate opened our mind to be able to do more targeted distribution. We realized we used to distribute about 7 to 8 million condoms per month. But now, after realizing our distribution channels, we're able to shoot that distribution to about 17 million per month. And we are still even seeing more need for condoms. There is also active participation of the private sector. So through the Senate, we're also able to realize how much condoms we needed through the total market approach, because that is also taken care of in the Senate. So we're able to resize our market so we know exactly how much contribution the private sector is able to give us, because all that is captured within the Senate. Equally, we were able to conduct hotspot mapping. These are GIS hotspots, and we're able to do a hotspot mapping of about 17,300 hotspots that are routinely distributed using our condom last mile distribution mechanism, which was strongly informed by the use of the Senate. Really, after our minds were opened up and realizing we had different channels that we would actually use to deliver the condoms from the targeting that we did when we were completing our Senate tool. This equally informed our tracking of the condoms. So addition to just mapping the hotspots, now that we know the need, we're also able to now go down and develop a tracking mechanism of all the condoms that we procure and distribute. And apparently, we have the last mile tracking application that is able to track condoms from the national warehouse all the way to the community. And by click of a button, we're able to see which hotspot is missing condoms. And all this has been informed through the Senate and specifically through the targeted distribution. Yeah, so going back, we used to have a wasted rate of about 33%. But from the Senate, we're now able to target more. And we realized even we have lowered that wastage rate to about 21%. Yeah, to us, I think that is significant because we think the condoms are not being wasted now, but they're going to the people who require them. Still, as you are all aware, the Senate emphasizes the total market approach. Yes, we have started tracking that as a program now. We know we have the three segments: the free-to-user condoms, we have the social marketing condoms, and the commercial brands. We see for the free-to-user, we have about 80% dominating the market. You see that social marketing about 20%. We have the commercial brands, which are at around 5%. But the beauty is we know who contributes to which percentage. And we believe in going further in the future for sustainability. We have already estimates that have been guided through the Senate that we think we should target, especially reducing the free-to-user condom to make sure that our market is sustainable. In terms of lessons learned, we realize really the Senate has helped us to be more precise on where we do our distribution and equally targeting the most at risk, the high-risk population. We have also noted that the Senate has now become our one-stop data center for condom programming. We know all our condom needs and our condom requirements, and we're able to access it within a click of a button. As I hinted earlier, the Senate has also sort of like given us a baseline for condom programming in terms of
I think we lost Boniface. It could be a network issue here. But he was rounding up around the lessons learned. Let's just give a few seconds. If he doesn't manage to join now, we can go to the next part of of this session, which will be an exercise that I'm looking forward to, more engaging and making sure that we know the practical part of this exercise, how to do it in Spectrum, the step by step, and how to read the outputs. Before I give back to John for that, let's just give Boniface a few seconds if he's going to be able to join. Okay, we'll allow him to maybe come in after the exercise, maybe to wrap up the last points or to just speak any key points you might have wanted to highlight at the end of his presentation. As you noted, he was now sharing the key lessons learned from the country. I would like to think this was maybe the last slide. So yeah, the next part is the exciting part, right? We've learned the theory side of things, how these tools work, what the tools do, the outputs you get from those tools. But the most important thing, especially the linking to these GC8 applications, is to be able to do it and generate something that you can then use in terms of your planning, in terms of writing your proposal. So this is the most exciting part of this workshop. I want to give back to John to help us or walk us through how do you do condom need estimation in Spectrum, a walkthrough. And as he does that, I want to encourage you to be following through. This is part of the exercise that we'd like to us to do now. So over to you, John. You will be able to better explain whether you have Spectrum already or you don't. Maybe you might need to download and install. Over to you, John. Yeah.
Thanks, Lysias. Yeah, so hopefully you've already downloaded Spectrum or are using Spectrum on the web from the exercise from yesterday. If not, there is a handout that Lysias has put in the share drive or can share with you to walk you through the steps. Basically, if you want to download Spectrum, you just go to avenirhealth.org website, and there's a page for Spectrum downloads. You download the install program and run it, and then you'll be ready to go. Or you can go to the Spectrum web address and establish a login and use that directly. So there are materials on how to do that, but hopefully you've all done that yesterday. So I just wanted to walk you through a quick example using Spectrum Desktop and then let you try it yourself. So once you've started Spectrum, you just need to open your official estimates file. And I'm going to pick on Uganda here because we just saw the example from it. So I'm telling it to load the Uganda Spectrum AIM file, and it's doing the loading right now. And once that's done, then the name shows up down here that confirms to me that I've opened that file. So with only one file open, that's the only one, I'm going to go to the Tools menu, select More Tools, and select Prevention Needs. And once I do that, then I come into the Prevention Needs tool. And here you can see we have the different tabs for condoms, circumcision, key populations, and PrEP. So we're going to focus on the condom one today. And so here it is. And you can see that it's pre-populated with information that comes from the database that we provide. But it's important that you review these inputs, as I mentioned earlier, to make sure they're correct for your country. For example, we just heard that Uganda is distributing about 200 million condoms a year. That's their 2024 submission to GAM said 207 million condoms. I haven't seen the 2025 number yet, but let's suppose it's close to 200 million. So this number that we're estimating right now for 2025 is too low. So we'd want to try to make sure that we can match the official number. So two things we learned from Boniface's presentation. One was that wastage is 21%. So instead of the 20% here, I can just change that to 21. And this is pretty unique. We don't usually see good estimates of wastage in most places. So if you have those estimates, you can change them. And that updates this a little bit, but it's still quite far. We're using the latest survey. We're using the best estimates we have of population size. So the other main uncertainty here is the number of sex acts per year for the different populations. And here we have some standards that we use, but these could vary a lot by country. So one thing that I noticed that if I just change these, the number of sex acts among people who have non-regular partners, if I raise that to 85, then we get a total 206 million, which very closely matches what Uganda is actually distributing. So this step is important because you want to be starting off in the right place. Otherwise, your targets are all going to grow from an incorrect base. So please review all these inputs. And if you have this information on number of condoms distributed, say, in 2024, if you don't have your 2025 numbers yet, and get something that looks close. Okay, then it's going to simply project for us based on the targets. So I've got my targets here, and it shows me that in order to achieve those targets, the number of condoms distributed would have to rise from 200 million to 360 million. And you can see where they're required. So the largest number here, 150 million, is among young people 15 to 24 with non-regular partners. The next highest number is for sex workers. And then you can see, some of the other groups here. So I see how they all add up to that number. So obviously the targets for young people and sex workers are critically important here because they have the biggest contribution to all this. So notice that not only is this a large increase, it implies 10 to 15% annual increase in condom distribution. So you need to think, is that feasible? Is that something we can do or not? You can change any of these targets. So if you want to say, maybe that sex worker target is a little too ambitious because with PrEP coming on now, maybe it'll be somewhat lower. So I changed it to 80%. And then you can see this number goes down and the total goes down. And all the intervening years go down because the model is giving you a linear extrapolation. So that's the process. Simply, number one, verify the input data. Number two, make sure that you're matching more or less with your best information from 2024 or 2025, and then review the targets and look and see how changing any of these targets changes your estimate of total need. And from this, you can construct a scenario where you say, we're going to have to increase condom use by this if we really want to reach these targets. So this is relatively easy to use. You can all try it out right now. This gives you the quick overview. And then if you're going to actually prepare a detailed section on condom use in your GCA application, then you probably want to use the CNET tool to get all the great details. So let me stop there. Happy to answer any questions. Otherwise, over to you to try it out.
Thank you so much, John. This is very helpful. So we have a couple of minutes here for you to follow through these steps, as John highlighted. If you missed anything, just highlight in the chat. We can ask John to move a few steps backwards for you to see the different steps. Then you can follow through because we'd like to have maybe a few minutes to reflect, for you to share your reflections, and also for you to ask any questions where it's not clear, maybe from the steps shared so far by John. What would like us to achieve is to be able to do this and to be able to get the outputs and to be able to do it ourselves as well. I see there are questions in the chat. Whilst we are trying out, I'll be asking our panelists to respond to these questions. Let me get to the Q&A. Okay.
Yes,
we can be trying out those steps whilst I go to these questions. A number of them, they've already been responded to already. Okay, so I see a few here that they haven't been responded to. One is explain again how the private sector was involved through the use of CNET. That's the question from Bilia Luaka. So this goes to Hank, I think. And then what strategies is Uganda using in the last mile distribution? I see Boniface has managed to join. So Boniface, I know you couldn't maybe finish the last bullets on your presentation, but feel free to respond to this question from Zambia, saying what strategies have you used in the last mile distribution, and what experience, if any, are there with condom dispensers and use of condom champions or community-based distributors? That's for Boniface. And then the other one, it's a comment from UNFPA. So those two questions, one for Henk and then one for Boniface. I think they can be responding to this while we are also figuring out that spectrum part that John showed us some steps how to do it. If you missed the end of those steps, feel free to highlight in the chat, and we can ask Johnny to project those steps again, just for you to see what to do and where to go.
Lysias, I just pasted the steps in the chat.
Okay, perfect.
Lysias, okay.
Yes.
On the question, the private sector, I'm not sure it's for me. It might be specific for Uganda, but I can comment in a general way on it. Because, I mean, private sector and CNET, we basically recommend very strongly when the process of using CNET is set up, that there is a core team that manages the tool and the process, but that there is an extensive stakeholder group that is being consulted and used to validate the estimates in CNET at all stages. And that stakeholder group should definitely involve private sector, as well as public, as well as civil society, community, and beneficiaries. And then we're talking every single population that's part and parcel and being addressed in condom programming. They should really be part of the process. So, and of course, often we see that there is not already a good multi-stakeholder coordination platform on condoms, which involves systematically all of these groups. And one of the effects of CNET is that actually such a group is being established and then further strengthened. Uganda definitely did this, and that is especially important when discussing on the TMA model, who provides which condoms to whom. These are important discussions and decisions to be taken. I know that in the Condom Special Initiative in Southern Africa, that this component was very much supported. And there is even increasingly an interest with the whole sustainability discussions in making sure that in condom programming, we proactively involve private sector and try to create more space for their contribution. Because that, of course, frees up resources for the public sector, and you also can tap into the comparative strengths of the private sector, which can be in condom promotion, publicity, etc. So that's the general idea behind it. I know it's being applied in a number of countries, but perhaps Uganda, or I think also people from Southern Africa, from UNFPA, I see Rosemary is connected, might want to comment on that. Thank you.
Maybe I would just respond to the question that was for Uganda. Yes, as Uganda, we have what we call the last mile distribution mechanism, which the country developed to ensure that we deliver condoms all the way to the community hotspots. And what we have been able to do, we've been able to identify a team of riders who pick condoms. We have what we call a regional hubs. Once the condoms are delivered from the national warehouse, we take them to a regional hub. And then we have a team of motorcycle riders who come and pick them and take them to the GIS mapped hotspots. So within each GIS mapped hotspot, we have what we call a hotspot manager. The hotspot manager is able to update now the application that we have. It's able to trigger a request that the condoms are out, and then the rider makes sure that he picks the condoms and delivers them to the app. That's one. And then two, we have already community established structures. These are organized groups that exist within the community. We have peers of different categories of the high risk populations. So within that mechanism as well, they're able to liaise with our hub managers and they're able to pick condoms directly. And then Uganda also has a system of community health workers. These health workers pick condoms from a nearby facility which they support and then deliver them directly to the communities that they support. So those are some of the different mechanisms that we are using to make sure that condoms are available at community level. And in terms of refilling the dispenser, the hotspot manager is the one who is responsible for ensuring that the dispenser is always refilled with condoms. Thank you, and over.
Thank you so much, Boniface, for that clarification. And the response to the question. So, yes, I'm checking again here questions here, and I like to think that you are following those steps, working through the two. We'll have some reflections at the end of this exercise session. Another quick question for you, Boniface. The person is saying it's Unit Ghana. Thank you so much for your presentation. I would like to know, how do you achieve active participation from the private sector? And then, okay, this is a request from a participant to go through the prep section as a recap as well. Okay, we will look into this last request. So maybe a quick response to that question, Boniface, and then people can focus on this exercise. We would like to do a reflection to see if everyone is comfortable doing this in Spectrum, as shown through the different steps by John here.
Okay, thank you. Our program, ESA stated earlier, we are able to work closely with the private sector, able to do the mapping, and to be more engaged with the private sector, we have what we call the National Condom Coordination Committee. And within that committee, it's a blend of all the civil society actors, the commercial actors, the social marketeers. So we meet every quarter and we discuss challenges that are affecting each one of us in terms of programming, and we try to identify solutions. That's one. But specifically for the private sector, we have what we call the Total Market Approach Task Force. So this one is purely for the private sector, and these teams sit equal on a quarterly basis. So actually they sit before the National Coordination Committee meeting sits. So within the task force, the TMA task force, are able to identify and generate issues that affect them, and then they are brought to the National Committee, which now is able to identify solutions. Yeah, and then equally, in terms of participation, we have what we call the support supervisions and the mentorship. So we identify equally partners who support the private sector to be able to participate in that support supervision and mentorship, as well as ensuring that even when we go to the district, we don't just focus on only government facilities. We also make sure that we go down to the hotspots and see how the condom programming initiatives are being conducted. Thank you, and over.
Thanks, Boniface. I see no additional. Okay, there's one on Wastage here. I would like to kindly ask maybe Hank or someone Clemens, or you, Boniface, if you could respond to this question by Elvis saying, what are the sources of condom wastage and where does the data come from? If you could maybe respond on that Q&A chat, because I want to let participants follow these steps. And then we have a Menti with my colleague to reflect on this exercise. So yeah, if you need any support on how to do this, feel free to send a help request in the chat and then we can help you.
Yeah, thank you. The issue on wastage, as a country, we conduct surveys, and we've just concluded one. We have a national survey, the WCA survey. One of the areas that we focus on is also to ensure that we pick information about condom wastage. And then we also have specifically surveys that are tailored for condom programming. And one of the key questions that we ask is whether condoms are being used correctly and consistently, whether out of, like, our pack is a pack of 3 pieces. So we ask, out of the 3, do you use them all or you use only one and throw the others? So that's how we have been able to pick out some of this information. We have those national surveys. Thank you.
Lysias, if you want, I can compliment.
Yes, sure, yeah.
Yeah, it's a while ago we looked at that, but what I can say, and I think John was even involved in that very long time ago, that the standard estimates in condoms for family planning used to say, and that's where the 100 condoms per year come from, was then the recommendation was to say 100 actual use and 20% wastage. So that was a bit of an orientation. As been said, there is no really very good data and solid data on condom wastage. Great to hear what Boniface was saying from Uganda. So it's also by applying CNET, talking to people, it's a bit of expert opinion and getting feedback. I think PSI in the social marketing did some estimates, all of that mixed up. What was important was not to underestimate in the CNET, not to underestimate wastage. And also what we also did was a kind of logical pathway of every step from the condom distribution process. Check where do condoms get lost and what reasonable amounts get lost. And it also has variable per population. It has to do with how well targeted your program is. If you distribute a lot of condoms to people who really don't need them or don't use them, you get a lot of wastage at the user end. If you procure too many condoms and you don't have a good distribution system, then many condoms get lost in your warehouses or expire, and we all know stories about that. So there's many variables that come in, and the 20% seems to be kind of right as a starting point for discussion, but then can be adjusted by the countries, by the users, given the country-specific context. Just one anecdote, in one country where we were doing this, we were ending up with suspecting that up to 30 to 50% of the condoms did not end up being used by people who actually needed them. And that gives you a strong signal on the importance of this kind of targeting and identifying needs and capacity to actually distribute and provide access to condoms. So it's a complex thing, but it's an interesting one if you really start unpacking it with all your stakeholders and try to take an informed decision about that.
Thank you so much. Yeah, and it's great to see people engaging this way. A lot of questions, a lot of clarifying and follow-up questions from colleagues, very engaging, which is good to see. I hope at the same time, as these questions have been responded to, you were also able to do a quick walkthrough following those steps that John highlighted. I want to hand over to my colleague Heather Marie to do a quick Menti on this, and then we can go to the last part of the session today. So over to you, Heather Marie. Boniface, if you don't mind to respond, there's a question for you in the Q&A. If you can type it there, we no longer have much time, I think, to speak back to some of these questions. So if you can check that Q&A and respond directly there, we can always follow through if the participant is okay with the responses or need further clarification. Over to you, Heather Marie.
Hi, everyone, and we are back with Mentimeter. So if you're still logged in, this is super easy. If you haven't, please scan the QR code or go to www.menti.com. It's the same code, it's the same presentation. So if you're already on, this is brilliant. You can just keep going. Okay, so we have two questions right now. The first question is, for those of you who are able to get into Spectrum and have started to play around, what is one thing that surprised you about the inputs into the Spectrum needs estimates? Sorry, the Spectrum prevention needs estimates. Was there anything? Maybe there was nothing that surprised you and it went just as you thought. Question. So was there anything about the inputs, so the data that was included there, the way that, for example, you can modify the data? Was there anything there that you were like, this was surprising, I didn't know I could do this, or I didn't expect that I could do this? Something that you were like, this is amazing that we can see this data. So we have a few questions coming in. So something that was surprising was the limited outputs, for example, the flexibility. A few people have responded that this is something that did surprise them. Simplicity, that's great. The modifications, simplicity, accessibility or accessibilidad, and the user friendliness. Okay, that's amazing. So this seems to be something that's coming up for a lot of people. The modification, the quantification, and how much thought was put into it. I think this is a lovely compliment to the Avenir team and everybody who was involved. So I know that many of you will only just be starting to have a look at this and explore it. We do have one more question, and it is about the results, which I'll skip over to for those of you who have managed to produce a couple of demonstration results in just a minute. So last chance. The invention. Doable. Oh, wastage. Yes, that was something that came up in the chat and the discussion quite a lot. Okay, so we will thank you for your responses on this. Now, for those of you who have managed to produce some results, was there anything there that surprised you? Whether it was about the results themselves, the way that they were presented, the way that, you know, maybe the results themselves were surprising, not what you expected to get out. Accuracy has come up. Limited outputs. So I'm hoping that it was a positive response to the result presentation and not that that it wasn't good. So I'll allow just a few more seconds on this, and I realize that this is very difficult to answer now, as many of you may not have fully gotten to this stage. So no priority population. Perhaps this can be commented on, and in a minute I will also ask my colleagues whether there was anything about these results, so from John or Hank or Clemens, that they thought from your responses were quite important. Accuracy is coming up for a few people. Multiple utilization, results make sense. So again, accuracy. Okay, just a few more seconds. Oh, I need to takes decisions. Okay, so perhaps handing back over to you, Lucius, and maybe we can get some reflections from John or from Hank or Clemens about the results that are coming in.
Thanks. Thanks, Heather Marie. And I think yeah, maybe what we could do is to go to the next part of this and have maybe quick overviews of those presentations that we have. One very short one on VMMC, and then another short one on key populations. Then another one on cost effectiveness modeling using the GOES model. So those three short presentations would like to cover that, because we want to come back and then link this in an overall discussion around the GC8 applications, any country support needs, things like that. So I want to give and then during that we can also reflect on the responses from participants. So over to you, John, I think for a very quick overview of VMMC needs in Spectrum. And then after you, Eileen, on population-specific programs. And then after Eileen, Rob on cost effectiveness using GOES model. After that, then we can have an overall discussion and link this to GC8 application. So over to you, John. Yeah.
Okay, thanks, Lysias. So another tab in this prevention needs tool is for voluntary medical male circumcision. And the purpose, of course, is to assist country teams estimate the number of VMMCs required annually to achieve their targets. Similar to the other tools, we set a target for 2030, and in this case, it's done by district instead of by population group, by geography, for males 15 to 29. So just a couple slides of background. This shows for the countries that have VMMC programs, the annual number of VMMCs conducted as reported to the GAM, with a peak around 2018, 2019. Last reported year so far, 2024, a little over 3 million. So why is this important? Well, when we model the impacts of VMMC, we can see that they're quite substantial. This chart shows you the cumulative number of infections averted by VMMC programs since they started back in 2008, 2009. So if you look up to 2025, you can see it's about 800,000 infections averted. But then the line continues, and this represents what would happen even if we did no more circumcisions. But the young men already circumcised will continue to have protection, to receive protection throughout the rest of their sexual lifetimes. So the number of circumcisions, the number of infections averted over the long term rises to 2.5 million. You can see by 2050. So this is a highly impactful program. So here you can see the results. We estimate that through today, there's been about 1 infection averted for every 50 or so VMMCs conducted. But when we take account for the full credit through 2050, that number drops quite a bit to about 1 for every 17 circumcisions. So this is very cost effective and in some cases cost savings because of the people that do not need to be treated. Just to note that even though the circumcisions are provided to men, when men are protected, then their female partners are protected. So over the long term, a little less than half of those infections averted are among women. And as I said, it's important to assess VMMC over the long term. So the targets in the global strategy are 90% of males 15 to 29 are circumcised, either traditionally or through VMMC in the priority countries. The tool then looks much like the other tools, except now the rows are geographic locations. So they could be districts or regions in your country. But then once we have that, we have the male population, we have the current circumcision coverage, which is coming from your most recent survey. And if that survey is a bit old, then it's been projected forward based on your data on number of circumcisions conducted since the survey. So it's certainly something to review and look at. And we have the target coverage. And then we also have traditional circumcision here because we assume that traditional circumcision continues. So that VMMC programs are needed only to add on to the traditional circumcision rate to get up to the target. If that assumption is incorrect, you can modify the traditional circumcision rate to show that some people are switching from traditional to the VMMC program. And then the outputs in green show you the number of men circumcised by year and the total number of new VMMCs required each year. Okay, so just to say, in the final slide here, that these current level circumcisions are informed by the most recent survey, so that might be a little bit out of date by now. So you want to check that to make sure that it matches with your best program estimates. And also what I mentioned about traditional circumcision continuing, that might not be the case in many places. In places where traditional circumcision was quite low to begin with, most of the countries in the southern part of the region, this may not make much of a difference, but in some of the countries in East Africa where traditional circumcision rates were higher among some populations, this could make a big difference. So it's something to take a look at. Thanks, I'll stop there and happy to answer any questions.
Thank you so much, John, for walking through that so quickly and highlighting the key features of this part on estimating the need for VMMC. I want us to go into the next presentation. If you've got any questions on this, feel free to post in the Q&A chat. We'll be following that and asking the presenters to respond there, as we might not have enough time to speak over the responses. So over to you, Eileen, to share on key populations size estimates. As we know, to understand prevention need, it's good to know, or it's important to know the size and substantial risk of acquiring HIV. That will help us to estimate the need for prevention programs. So over to you, Eileen, for that presentation. I'm not sure, Eileen, if you are there.
Hello, hi, Lysias. Yes, I am there. I admit that I have not counted on this presentation now.
So we could also just look at the tab
Yeah.
in the spectrum and briefly speak to that.
Sure. How do you want to proceed? Do you have anything ready, or?
Would you like me to show the tab, and then I can make a few comments, and Elena can follow up with that?
Yeah.
Sure.
Okay, sure.
All right, let me see if I can share my screen again. Okay, so we're talking about the tab for key populations right now. And so if you go to that tab, what you'll see is the rows now are the key populations. And the inputs here are the size, the number of people in each of these populations, the current coverage, and also some information about the source. Do you have a specific IBBS that gave you this information? Or in our database, if we didn't have that, we might have used a regional average, or we might have used some data that was in the key population atlas from UNAIDS. And then you input your targets here, and the calculations are quite simple. It's simply the population size times the target coverage. And here you'll see the number of people that need to be reached. And in this case, since the current coverage of programs is quite low compared to the targets, there's a huge increase here. So the targets are pretty clear. You may have better information on current population reach than we have in our database, so please look at that. And then obviously very key to the inputs here is the population size estimates. And I think I'll let Elena comment on how those are derived. Over to you, Elena.
Yeah, thanks very much, John. So if I'm correct, and I asked you to verify, John, the population sizes shown here are as in the latest goals file for each country.
Correct.
Yes, and the goals files were updated by Avenir Health in around September, based on the official latest AIM estimate for the national epidemic, and stratification by key populations based on country reported GAM data, so population size reported into GAM, and also considering systematic review done with Imperial College London that considered the same data and additional published peer-reviewed national size estimates that were valid, but not necessarily reported through GAM. I think that was pretty much it, and we'd be happy to share that publication where you can see that for mostly African countries, the estimate of the population size. I think they're pretty much adopted in goals, and so showing here as well without further change. These looks at the most reasonable data set, and that's the same that was used by UNAIDS this December for the World AIDS Day report as the basis for the updated key population infection estimates, such that yeah, it's a coherent data set.
Thanks so much, Ellen. That's super helpful, and thanks also, John, for showing that tab in Spectrum. Maybe a quick question that we're seeing, Ellen, is maybe according to the key population definitions from UNAIDS, why prisoners are not there on this tab. Not sure if you could respond to that. Yeah.
Sure. So the goals model distinguishes, I think, 3 or 4 key populations by risk behavior. They are men who have sex with men, sex workers, female sex workers notably, and intravenous drug users. And those are associated with specific risk behaviors that increase the risk of HIV. Being in prison by itself is not like a biomedical risk factor for contracting HIV. Of course, a lot of people in prison share the same risk factors as the 3 groups I just mentioned. And indeed, there's a lot of overlap between them. that is why goals like other risk models do not distinguish prisoners as a separate group. There will be a risk of double counting and overstating the total risk. So instead of quantifying that, the share of prisoners in the burden and in the population at risk is captured under the other risk groups.
Thanks, Eileen. And I want to give also to my colleague Clemens here to give some reflections around using the KP data for programming, HIV prevention programming. Over to you, Clemens. And just to also highlight that we are going to have other dedicated sessions on concentrated epidemics where we'll also go into detail on key populations programming, and we'll go into detail in those sessions. Feel free to join those workshops as well for more detailed look into key populations programs. Over to you, Clemens, and then we can go to Rob for the goals presentation.
Thanks so much. And John, I mean, if you like to keep it the key population tab up for a moment, that's fine. Otherwise, I can also just speak to it. Maybe to start with on the prisons, practically, we have it in the scorecards, prevention scorecard files from the World Prison Brief. So numbers are available in terms of population sizes. Of course, for practical reasons and programming reasons, prisons are a platform, and then you could use those numbers that you may have available in country or from the World Prison Brief as a basis for planning. And of course, it's not possible because of those overlaps to model them in the transmission models. But for practical reasons, you can still use such data for programming. Perhaps programmatically, we sometimes get the question, and what does this mean for programming to have these population sizes and targets? And what we see is quite a major transition where traditionally we have said, virtually everyone needs to be reached either, with a clinical service every 3 months or maybe by a peer outreach worker every month. There are quite some shifts now with the limited resources available. And of course, there's great opportunities and good examples for virtual programming. So as we've shown in the beginning in the prevention access framework, you could actually take these targets and then see, how do they need to be modified? And there's no global formula to say what percentage should be virtually reached through some kind of virtual platform or peer outreach or, clinical service points. But it's a combination of those 3 broad categories that would achieve those numbers reach for the demand side or for offering access platforms for the different prevention options like condoms or PrEP or harm reduction, whatever it may be for the specific populations. So that's just a note, and there's also a guide, a programming guide on key populations trusted access platform, and one on demand generation, which go into much more detail on how to use such numbers. Thanks.
Clemens. I hope that's helpful. And as I highlighted earlier on, we're going to have concentrated epidemic dedicated sessions over the next few weeks. We will share a link with all the Zoom links of all those sessions, and you are free to join those sessions to go deep dive into KP programming. Over to you, Rob, for the last presentations, and then we can have some reflection.
Great. Thank you, Lysias. I'm setting up sharing now. Hopefully you can all see my screen. And so I'm happy to have the chance to talk about cost effectiveness modeling in the context of this meeting, where we have been talking about some high-level targets for HIV prevention services, but also recognizing that we're in an environment where funding has been shifting and contracting rapidly, and trying to balance these concerns, wanting to prevent as many infections as we can against potentially having less resources than we have in the past. And cost effectiveness is a tool that can help us weigh some of the decisions and considerations. For those of you who aren't familiar, GOALS is a compartmental HIV epidemic model that simulates HIV epidemic dynamics and intervention impacts. And I know there are a lot of familiar faces on the call, and I know many of you have actually received some training on GOALS through estimates workshops last year and previously. But one of the things that we use goals for is to evaluate the cost effectiveness of interventions, as well as looking at historical and potential impact of your HIV programming and reaching coverage targets. And goals has been applied all over the world to evaluate UNAIDS global AIDS strategies, national strategic plans, your HIV investment cases, and global fund applications. Goals is well suited for these kinds of analyses because it models HIV transmission by population groups based off the behaviors in those groups, various epidemiological factors, and the impact that interventions have on either behaviors or on HIV transmission risks, depending on whether we're talking about interventions like outreach services for key populations that we anticipate affect the behaviors that expose people to HIV risk, or biomedical interventions like treatment and PrEP that directly affect the risk of HIV transmission within sexual partnerships. So, as many of you know, we at Avenir have been working with UNAIDS and the Gates Foundation to provide modeling support to a number of countries in the region to assist with planning largely around the shifting funding landscape. And so I wanted to talk just briefly through some of the results that are coming out of these activities. So for a lot of these countries, we started with a cost effectiveness analysis of several sort of key common HIV programs, and we looked at them in comparison to just maintaining treatment alone. And we looked at the outcomes through 2050 so that we'd capture some of the long-term benefits of HIV prevention. And we look at this in the context of the cost per disability adjusted life year averted, so DALYs averted, rather than looking in terms of something like new infections averted, because in the funding reality we're in, where HIV funding is being shared with funding for other health areas, we want to look at outcomes that are comparable across health areas, whereas looking at things in terms of cost per HIV infection averted is really only able to compare things that you're doing specifically around HIV. Now, just a word on unit costs that we've been using costs that were developed to help evaluate the UNAIDS global targets, but with some adjustments to align the costs we're using with expenditure reporting that you've put into GAM and GARP over the years. So this slide is just summarizing the results from some of these cost effectiveness analyses for 13 countries. On the x-axis, we have the, let me get a pointer here. On the x-axis, we have the different programs that we've evaluated. So condom supply and promotion, and a PrEP mix for key populations, oral PrEP alone for key populations, services for key populations, VMMC, and PrEP for the general population, by which we mean specifically women with multiple partners. Now, the points on this graph show the cost per DALY averted in individual countries, and then the box and whiskers show the median and interquartile range of those cost effectiveness ratios. So over on the left, you see condom supply and promotion, which is below the zero line because it was both reducing disability adjusted life years and reducing long-term treatment costs in almost every country we've looked at. The other programs, we see a bit more heterogeneity. Sometimes PrEP for key populations is cost savings. Other times it can be quite expensive. And this takes us to the point that context is really key. We can see quite a bit of variation in the cost effectiveness of interventions across different countries. And this is another way of looking at these same analyses. Instead of showing the disability adjusted life years, the cost per DALY averted, what we're looking at here is for each of these countries, which I've anonymized just to focus on the cost effectiveness component. Across these 13 countries, we've taken all of the interventions we evaluated in each. Some were omitted for one reason or another. But of the interventions we evaluated, we ranked them where 1 is the most cost effective, 2 is the next most, so on down to 10 being the least cost effective. And then we sorted this whole list by the average cost effectiveness rank. And this, again, just shows condom promotion coming out as the most cost effective in most of the settings, in almost all of the settings that we're looking at. Treatment comes in close behind, and then we see the cost effectiveness for key population PrEP and sex worker programs coming in next. Now, you do see programs for men who have sex with men and people who inject drugs coming in low in this analysis. And that's a bit of a cause for concern because often the data that we're working with for those populations are quite uncertain. We don't have a lot of data on these a lot of prevalence and incidence data on these populations in the region. And so that poses some risk that we underestimate how cost effective it is to reach those populations. And so that's something to consider when evaluating an analysis like the ones that we're doing. Now, I did want to mention that the cost effectiveness of HIV prevention is really driven primarily by 3 key drivers: the HIV incidence in the population reached with each program, just how effective the intervention is per person reached at reducing incidence, and just how expensive it is per person reached with each intervention. And so those are things to keep in mind if you have a program that you're interested to do and want to maximize its cost effectiveness. Try to reach higher risk populations with effective interventions at a reasonably low cost to the extent that you're able. Now, how do we use the results of cost effectiveness analysis? Well, this is looking at a resource needs calculation that we worked on with Malawi in late 2024 in anticipation of potential funding cuts, where we looked at resources available under the status quo, which you see as the height of the bars, and what we thought might happen going forward based on anticipated funding cuts. And that's the line that you see in red. And so we can use cost effectiveness analyses in conjunction with these funding envelopes to look at potential impact scenarios. So you can see here the anticipated new infections under the status quo scenario if we kept doing the same things we had been doing. The orange curve shows what might happen if those same resources were available but prioritized on the basis of cost effectiveness, which could potentially lead to a substantially lower projection of new HIV infections. And then this green curve shows if we use that optimization approach but did have less funding available. And this gives some sense of how optimization of available resources could help offset some of the impacts of potential funding cuts. So that's one way that we can use the results of cost effectiveness. And so it can help guide program optimization, but I do just want to again emphasize that cost effectiveness analysis is really sensitive to several uncertain factors: the costs and impacts of interventions and the HIV incidence in the populations that we're reaching. And I also want to just recognize that cost effectiveness is only one component of decision making. Some of the programs that we often evaluate, like condom distribution, have benefits beyond the HIV space, but a model like GOALS and a lot of the other HIV-specific models out there will only capture the HIV-specific benefits. Another is that a program optimized on the basis of cost effectiveness alone could potentially be inequitable. And so we'll need to be on the lookout for those kinds of issues in the recommendations that come out of such an analysis. A model like GOALS also does not necessarily recognize your capacity to move human, financial, or other resources between programs. It's easy in the model to say we can put all of our funding into this or that, but the reality on the ground may be different. And so because of all of these considerations, we don't like to do these kinds of analyses as a desk exercise. We want to engage with you and other experts in your countries, and you should really lead those efforts to help tailor the modeling to the national context, both in terms of the inputs, the assumptions, the constraints, and as well as the bigger picture, making sure that we're answering the questions that are actually of the most relevance to you as we do these kinds of analyses. And thanks. I did kind of move through that quickly in the interest of time, but I hope that this was useful, and I'm glad to take questions in chat. So I will turn this back over to the chair. Thanks.
Thanks so much, Rob, and thanks for helping us get some few minutes there. So that was the last presentation for today, a continuation from yesterday. I want to give to my colleague Heather Marie here for a very quick reflection on this, and then if we can just a few minutes to then try and have quick reflections and linking this to the GC8, for which I'll give to my colleague Clemens for that. So over to Heather Marie for that bit.
Sorry, Lucia, so you're referring to the Mentimeter?
Yes, yeah.
Thank you. So everybody, just give me a second, but we are back to the Mentimeter. I'm assuming, hopefully, that you have stayed in. This is the last two questions for today's session. So we will try and do these quite quickly. So back to a question that we asked you this morning. After going through the presentations today and also having just a little bit of time to play with the spectrum prevention needs estimates tools, how confident are you feeling about using these tools now? And if you recall, the average was about 3.3 this morning. And I will give you just a little bit more time to respond. We've got about 13 responses so far. So it is a little bit like fastest finger first. Please do respond as quickly as you can before I move on to the next question. So overall, I think there is very much a stronger trend towards there being a little bit more confidence than there was even at the beginning of today's session, which is very encouraging. Okay, so we will move on to the next question, and this one requires you to think slightly more. But how do you see your country using these tools or the results from these tools in 2026? So do you think that these will be useful? How do you think your country might use them? And in just a few words. So for planning and procurement estimates for gaps analysis, thank you to colleagues who are very fast. Yes, very useful for planning, procurement plans, GC8 applications. This is one of the things we were hoping. It's been challenging. There has been a lot of content coming through today. And we know that it'll take a little bit to go through and to familiarize yourself and get used to these. Oh, here we go. A new feature on Mentimeter. I love this. We've got responses on it being useful, 5 responses on GC8, procurement planning, and GC8 hasn't been characterized yet. Okay, so noting that we are at time, I will hand back over to Clemens, but thank you. And please continue to contribute towards this question if you haven't quite managed to do this yet.
Thank you. Thanks so much. I will take over the screen in a moment, so please complete your inputs here. Lysias, I guess we can close, or are there any other burning issues that anybody would like to raise before we close?
Yeah, I don't see any questions that have been responded to now. If so, we'll go through this chat again, and then we can include maybe in some notes when we share the recordings and slides if there are any questions that have been responded to. Otherwise, yeah, we could close. And colleagues, if you are still not 100% confident, some of the sessions will be repeated in sessions for other regions as well. Feel free to join so that you can become more and more confident on these tools. Yeah, over.
Thanks so much, Lysias. Well, and thanks to everyone, first of all, the presenters from Avenir Health and colleagues in UNAIDS, and everyone who has contributed to preparing this new tool. It is a new experience, and it is actually coming at a very critical time. And we just had a conversation with NAC managers in the Global Prevention Coalition. We have, the countries with the 38 largest epidemics in low and middle income countries. And they really have one key challenge at the moment in this environment is actually understanding what is needed for prevention, what is priority, and how can they, in a new framing, put this across to the different domestic and international funding partners when resources are scarce. And they really see this new framework, this prevention framework, which this feeds into as one of the options, and these prevention needs estimates as a critical element of it to actually quantify what is needed. And this is why I've pulled up this one slide. I hope you can see it, which is just this table that describes maybe in one snapshot what you need to be in the driving seat on prevention. And the needs estimates are really the starting point. So from this, I hope this was useful for you to familiarize yourself with them. Perhaps you will have opportunity to review your country inputs and update them in Spectrum. And then the idea would, of course, be for any of those who are already this year or maybe in the next 18 months updating your prevention plans, that these targets and needs estimates could help inform that. And really, I think what NAG managers and ourselves see as the opportunity here is to put countries in the driving seat and develop your own needs estimates on that basis, and then have those negotiations with government where there may be need for new domestic financing or with specific donors to identify priority needs and investments in line with these broad brushstrokes numbers here, which of course can all be adapted at country level. So I think important to be practical, feed this into your planning processes. GC8 was mentioned a lot of times, and Global Fund is also engaged at this global level, so that going back, we can use this for leading our countries into an entirely new way, systematic way of managing prevention, which in a way is really, again, an area where the HIV response can become a model for public health. So thanks so much. And yeah, looking forward to future engagements. Give us additional feedback. This was the first workshops, and we'll take the lessons into the subsequent ones. Thanks so much. Looking forward to working together with all of you. Thanks. colleagues, any additions, or we can otherwise close, colleagues?
Thank you, Clemens. Thank you. Nothing from us. Thanks to everyone. See you in next sessions. For those who are going to join the other regional workshops, feel free to come. Yeah. I think we can end recording.